Who's joining us today. My name is Megan, and I am the program coordinator with the Riverside Medical Clinic Charitable Foundation. And we hold these webinars about different topics regarding endometriosis monthly. And so we would love to have you all join us again. If for some reason you have to log out of this one early, or you know someone who you wish it had been here for it, a recording will be sent out after, so you can share that or watch it again, and it'll be up on our YouTube page. So with that, I'm going to introduce our speaker today. This is Dr. Bayrak. He is founder and medical director of LA IVF Group. It's a group of fertility clinics in SoCal, and he is one of the most highly regarded fertility experts in the U.S. and internationally. So I'll pass it over to him now.
Great, thank you so much. Megan, give me 1 second. Let me adjust my screen here. It's great to be in this webinar. I think the last one we did about endometriosis focused on pain control with endometriosis. Today I'd like to touch base on that, but more so I'd like to focus on infertility treatments and options when somebody has endometriosis and is looking into treatments to become pregnant, or who's planning on that pregnancy in the near future. So let me just talk about just endometriosis in general for a few minutes. Endometriosis is a benign disease, meaning it's not cancer. And when these cells called endometrial cells inside the uterus that are present outside of the uterus in certain locations that they're not supposed to be, that disease is called basically endometriosis. So these cells inside the uterine canal, they come out through the menstrual flow every month and vaginally, but oftentimes they go backwards through the fallopian tubes and they spill into the abdomen. And most people believe that these cells stick onto certain tissues or the membrane that covers our pelvic organs and abdominal organs called the peritoneum. And they stick onto these tissues and they act as if they're inside a uterus. And due to hormonal changes each month, they then cause inflammation because the endometrial cells are not supposed to be on the surfaces of the peritoneum or fallopian tubes or ovaries, intestines, bladder, and sometimes even unusually can go up in the diaphragm and even into the lung. It's a fairly common disease, endometriosis. Some people, it's 1 in 10, 1 in 20 women have endometriosis. It's certainly more common in the infertility population, and it's very common in somebody who has chronic pelvic pain. Endometriosis can affect a lot of different things. Just in general, it can affect one's health. It's considered to be an immunological disorder, and it can coexist with other immunological disorders like lupus or connective tissue disorders, visual issues, kidney problems. One of the most common issues is thyroid problems. Low or hypothyroidism is certainly a coexisting disease. Endometriosis can cause pain by invading into the pelvic organs and invading into the nervous system, where they cause pain by pressing on the nerves. And that can be apparent as just random pelvic pain, continuous pelvic pain, cyclical pain. It can be sharp, it can be dull. It can be during intercourse, it can be during ovulation, or it can be during periods. So it can really present with different types, durations, and locations. It can affect infertility because it can cause inflammation. It can block the fallopian tubes. It can affect implantation at the level of the uterus. It can distort the anatomy. So it can really cause many issues and problems. It's difficult to diagnose endometriosis because there's no one clear test, like a blood test or an ultrasound or a CAT scan or MRI or an imaging study that we can do to identify endometriosis. And the reason for that is there's just no good markers. Oftentimes, an exam, an ultrasound, some blood work, and combination of these along with symptoms typically give us a diagnosis of endometriosis, but it's a presumed diagnosis. The true final diagnosis is typically given during surgery, where we are able to see the lesions and even take a small piece called a biopsy and send it to the pathology department to document that patient has endometriosis. That is not necessary for treatment, but certainly that is the gold standard for treatment and diagnosis. So there are many different types of medical treatments. I'm not going to go into every single detail today. I'm just going to mention a few. There's an old drug called danazol. It's not that popular these days, but in certain patients, it actually can be beneficial. It just has a lot of side effects, but it does appear to be highly efficient in taking care of pain. There are certain progesterone type medications such as Provera. There's a medication called Megace. There's an injectable progesterone. There's a drug called norethindrone. There is an IUD where a device is placed inside the uterus which releases progesterone, and these appear to relieve endometriosis-related pain. One of the most common things that we use, or medications that we use, is birth control pills. They give us good cycle control, less bleeding, less pain. Um, Typically, birth control pills prevent the formation of new endometriotic lesions. They suppress the old lesions. If somebody has a cyst in the ovaries, it can actually shrink it a little bit. And it's really great for pain control. There's another group of medications called GnRH agonists. The commonly known one in the US is called Lupron. And this basically makes somebody menopausal temporarily. It just shuts down all the estrogen production, and it is highly effective with pain control. It's just that it has certain side effects such as hot flashes, vaginal dryness, decreased libido, headaches. And if it's used more than a certain period of time, like over a year or two, it can actually result in bone loss. So oftentimes this medication is combined with either birth control pills or a low dose hormone, so that we can alleviate these symptoms and prevent both bone loss. And that's called add-back therapy in general. There are other medications like gestrinone and other progestational agents, some of which are available in the US, some of are not, that have been shown to control pain. When we go down to the surgical options, typically surgery is done through the minimally invasive approach these days. That's called laparoscopy. It's a day surgery. Typically patients come in, have the surgery, and they go home the same day. And the goal is really to remove endometriotic lesions, clear the cyst within the ovaries, clear any scar tissue, and try to restore the normal anatomy, especially in infertility patients. The risks can be minimal in somebody who has never had surgery versus quite high in somebody who had previous endometriotic surgery, endometriosis treatment surgery, as well as if in somebody who has pelvic adhesions. The pain control with surgery is actually dramatically well, and it's quite similar to medical management. Based on studies, pain control can be almost up to 100%, although it's never 100%. And plus, pain actually can come back. Typically, within 5 years, if somebody has severe endometriosis, pain can come back maybe by about 30 to 50% of the cases. Definitive surgery is typically considered as hysterectomy, removal of the uterus, as well as the tubes and the ovaries, although it depends on how old the patient is, what the circumstances are. So that management changes, and that approach must be individualized. Important thing is, if the uterus is removed and the ovaries are left inside we just need to make sure that all other endometriotic lesions are cleared, because otherwise the pain will still come back. The medical management does not improve anything related to fertility. So let's talk about fertility management in the presence of endometriosis. So if somebody has endometriosis and they would like to become pregnant immediately, medical management typically doesn't help. It doesn't improve the success rates, whereas surgical management certainly does. There's one exception to medical management and improvement of fertility rates, which is in cases of IVF treatment. If somebody has severe endometriosis, stage 3 or 4, and that patient either had done IVF and failed, or is about to start IVF, the pre-treatment with the GnRH agonist called Lupron can be considered. And there are a couple of studies that looked at pregnancy rates with pre-treatment using Lupron followed by IVF treatment, and it appears to be that the pregnancy rates are actually better in such cases. So that's certainly one thing that can be considered. But aside from that, medical management really doesn't improve spontaneous conception or just in general fertility. Surgical management, on the other hand, obviously does. In early stages, stage 1 and 2, it appears to be beneficial. Not for everybody, but certainly to a certain degree. People benefit maybe another 10 or 15% over their baseline chances. In cases where there's severe endometriosis and the tubes are blocked or there's adhesions, and if the surgery can be done successfully, success rates can be as high as 30 to 40% after those type of surgeries. If somebody had one surgery to improve their fertility and now endometriosis is back, doing second, third, fourth surgery does not typically improve fertility and rarely pain either. Typically, if there's endometriosis inside the ovaries, we want to remove them because that can certainly cause a toxic environment within the ovaries. And if somebody has ovarian involvement, we already know that they have lower egg reserve than somebody else in their age group. So in those cases, certainly removal of the endometrioma or the endometriosis, endometriotic lesions inside the ovary can improve spontaneous pregnancy rates. If somebody needs IVF, which is majority of the cases in stage 3 or 4 or advanced endometriosis, typically surgery is deferred unless there are significant symptoms. And IVF is typically offered to those patients because when we do surgery, we remove the cyst wall, but inadvertently, we almost always remove a little bit of that healthy tissue, and that does lower the egg reserve even further from a level that was already lower than ideal. That's why if IVF is going to be the mode of treatment for these patients, typically IVF is done first, and then if needed, surgery then follows. There are other treatments like Clomid or inseminations or injectable medications. They're typically helpful in stage 1 or 2 endometriosis or early endometriosis cases, but stage 3 or 4 or advanced endometriosis, they're typically not helpful. In terms of the pregnancy outcome, women with endometriosis tend to be higher risk, so they can have high blood pressure and kidney involvement, which is called preeclampsia, early labor, bleeding, placental complications, and there will always be increased risk for cesarean delivery, whether this is from endometriosis or other medical issues or associated risk factors or coexisting problems is unknown, but we certainly do know that these risks are greater. So I'll just stop here and answer any questions that you may have, because endometriosis is such a broad topic that we can talk about this for hours. So that's why let me stop and take questions for the next half an hour before we complete our webinar. So thank you so much for your attention, and I'll just be available
perfect.
for
So we
questions.
have some questions already, but for those of you that don't see the question spot, you can scroll down and write your questions in there. But our first question is, let's see, does being on birth control continuously for long periods of time affect fertility?
It doesn't, no. The tricky part of that question is if you have been on birth control pills for 20 years, for example, or 15 years, that means you're in your mid to late 30s. So when you stop the pills, you may experience infertility problems. That's typically not because of the birth control pills, but because of the reproductive age. So there's that bit of a confusion there. People say, I've been on the birth control pills for 20 years and then I had infertility. There's that, obviously duration. The longer you use, the longer you delay the pregnancy, and that causes issues with your egg reserve. So that's typically the
So our
answer to
next
that
question
question.
is, what exactly about endometriosis causes infertility?
So endometriosis can cause infertility because it's an inflammatory disease. So it can inflame the pelvic area. It can create a toxic environment in the pelvis where that toxic environment can be detrimental to the sperm and the egg and the fertilized embryo. It can also affect implantation. There are many studies that looked at inside of the endometrium and the molecular aspects of the endometrium and the implantation of the embryo into the endometrium or the uterus. And they found that women with endometriosis have lower implantation rates, lower conception rates. So those are the main issues. The second problem can be related to anatomy. The tubes can be blocked. If the tubes are blocked, then the egg and the sperm cannot meet. Obviously, that would cause infertility directly. Last not least, if somebody has advanced endometriosis, we call that stage 3 or 4 disease, they typically have lower egg reserve, meaning the endometriotic lesions or the cyst or this inflammation pretty much destroyed the eggs inside the ovaries. So women may have lower egg reserve than somebody else in their age group, which would then mean that they have more advanced reproductive age. Somebody at age 30 with advanced endometriosis, even though chronologically she may be 30, fertility age may be 35 or even 40 sometimes. And that certainly can cause infertility. So those are the main causes or mechanisms why endometriosis can cause infertility.
I've heard that endo causes miscarriages. Does that fall under infertility, or is that something different, and is that true?
That's probably true. It's not wide knowledge or established that women with endometriosis are at a significantly greater risk for miscarriages. There's certainly a problem with the endometrium. The cells inside the endometrium are called endometrial cells. So even though those cells are exactly where they're supposed to be in women with endometriosis, there's something that's going on maybe genetically that those cells actually look a little different. They act different too. So that may be the mechanism why some people get pregnant, but they have a miscarriage because it's because of the endometrium and the overall endometriosis and its impact on the uterus. The second most common problem, probably even more common than any other cause, is the makeup of the embryo. If the chromosomal makeup of the embryo is poor, abnormal, if the embryo has more chromosomes than it should, which is called trisomies, that can result in a miscarriage. If somebody has advanced endometriosis, they're going to have lower egg reserve. Lower egg reserve typically results in low egg quality. Low egg quality results in low embryo quality. And low embryo quality typically results in a higher risk for miscarriages. So as we get older, the risk of miscarriage goes up naturally. And that just may be accelerated in some women with endometriosis. So somebody at age 35 who has a miscarriage risk of, let's say, 15 to 20%, if her egg reserve is low and similar to somebody at age 42, her risk of miscarriage is not similar to somebody at age 35. Her miscarriage rate is similar to somebody at age 42, which is probably maybe 50 or 60%. So that relationship has to be understood clearly, and that typically explains why the risk is higher for miscarriage in women with endometriosis.
Our next question kind of goes with that. It says, if you have a history of miscarriages, does this hurt the ability for IVF to work?
Just as a general concept, it doesn't. It just may affect the chances of finding a good embryo. If somebody had multiple miscarriages, that tells you about their overall case, and that tells you about the complexity and the difficulty of their case versus somebody who never had a miscarriage. So certainly there's a correlation, but just because somebody had miscarriages doesn't necessarily mean that they cannot get pregnant.
Can endo symptoms change during pregnancy?
They typically get better. Endometriosis stays dormant during pregnancy, so oftentimes people don't have any discomfort, pain, or any issues because they're also not bleeding. There's no menstrual flow, obviously, so there are no new lesions. And also, due to high progesterone levels, these lesions stay suppressed, so they don't grow. There are no new lesions that form. So pregnancy is actually probably the best treatment for endometriosis and related pain. So the answer is yeah, no, there's no advancement of
So our next
endometriosis.
question is, we have been trying unsuccessfully to get pregnant. How long should we keep trying before seeing a specialist?
If somebody's at age less than 35, 1 year, if the female or female partner age is over 35, 6 months.
Does anything about being on fertility meds or going through IVF possibly make endo worse?
The actual injections don't make it worse. Endometriosis does feed up on estrogen hormone. So if you're exposed to estrogen for a prolonged period of time, endometriosis may get worse. And all of these treatments, the birth control pills and the progesterone hormones, injections, IUD, everything else is really aimed towards lowering the estrogen level or estrogen production. So there can be some correlation between prolonged estrogen exposure, whether that's with IVF or just in general, is certainly the case. But the actual IVF injections making endometriosis worse is not the case.
The next question is, can you explain how IVF works? Is it the first choice when it comes to infertility, or are there less drastic steps I can take first?
That's a good question. So if the endometriosis stage is stage 1 or 2, which is minimal or mild disease, one can try a medication called Clomid and do inseminations or IUI. That doesn't really increase the chances dramatically, but it'll increase the chances compared to no treatment or just trying on their own. And that's typically done for about 3 to 4 months maximum. Clomid allows a woman to release more than one egg. And with that, if somebody releases 2 eggs or 3 eggs, then that's almost trying for 2 or 3 months. And then insemination refers to injecting the sperm inside the uterus at the time of ovulation. So that's good for timing. It'll increase the chances with Clomid treatment. And also, if there are minor sperm problems, in addition to endometriosis, then it can certainly be beneficial. If somebody has stage 3 or 4 disease or moderate or severe endometriosis, typically other modalities do not work, and the patients are typically recommended to undergo IVF. Also, in these cases, time is an issue because their egg reserve is oftentimes low. We don't want to lose any more time with interventions that are going to not yield high pregnancy rates. So stage 3 and 4 directly to IVF. Stage 1 and 2, a couple of months of inseminations or Clomid are totally reasonable. If they don't work, then patients typically go to IVF. Most patients eventually end up doing IVF when they have endometriosis, and especially if they have a long history of infertility. If they've been trying for 2 or 3 years, then it's probably not going to work with anything other than IVF.
So our next question is, do I need to see a certain type of IVF specialist for endometriosis, or will anyone know about the condition?
All infertility specialists defined as reproductive endocrinology and infertility specialists can treat endometriosis, so they don't have to look for somebody who specializes in endometriosis. We all do. The key would be to get an evaluation by somebody who specializes in infertility and IVF treatment. If the goal is to have surgery for endometriosis, once again, majority of these surgeries can be done by any infertility doctor or their OBGYNs. There are certain cases where if somebody had a previous surgery and they had extensive adhesions, or if they had a complication in the past, then typically those cases are referred to either academic institutions or to certain laparoscopic surgeons who only do those type of surgeries. So that would be the only patients or times where somebody needs to kind of seek a subspecialist. Aside from that, any fertility doctor, anybody who trained as an infertility physician following their general OB/GYN residency, somebody who's board certified should be able to handle
So our
those
next
cases.
question is, I got pregnant very easily the first time, but now I'm struggling to get pregnant a second time after having laparoscopic excision surgery. Could this be why?
It depends on why the laparoscopic surgery was done. If it was her fallopian tubes, were they opened? Did she have, scar tissue? Does she have low egg reserve now? Maybe since the first pregnancy, now things have changed. It's hard to say. It can be from a number of different reasons. One has to look at the egg reserve very carefully, make sure there have not been any changes in the sperm. Make sure the hormone levels are good. Make sure AMH level is good. Anti-Mullerian hormone level is good to check on the egg reserve. And making sure that the surgery went well, it was successful, that there were no complications, there were no issues. So that's a discussion that the patient has to have with the doctor who operated on them to kind of review all the findings and make sure that there's nothing else that's going on. If they did surgery, maybe things got worse a little bit over time, or maybe she had a cyst, or maybe she had pain or more inflammation, which typically refers to more advanced disease. And maybe at this time they may need IVF, it sounds like. It's difficult to speculate without seeing all the facts, obviously, but that's kind of what's it's sounding like.
So our next question is, if IVF doesn't work the first time and you have endometriosis, is it possible for it to work the second time?
Yes, so each time we do IVF, the chances increase, and depending on the cause of the infertility, the degree of endometriosis, success rates can be 60-70% in somebody who has minimal disease versus 10 or 20% in somebody who has advanced disease. Somebody who has low egg reserve, chances are typically lower. So in those cases, some patients do multiple IVF cycles, multiple egg retrievals, and sometimes even multiple embryo transfers. One idea would be to test embryos to make sure they're chromosomally normal in such cases, especially if reserve is low, because most of the embryos are going to be abnormal chromosomally. So that would be an option to
Our
consider.
next question says, does anything about IVF make your pregnancy a higher risk?
Yes, and I think I mentioned that during the initial presentation part of the webinar. If somebody has endometriosis and they got pregnant on their own with IUI or IVF, they're at a great risk for preterm labor, high blood pressure, or what we call preeclampsia, increases for cesarean delivery, and certain other complications like high blood pressure during pregnancy. So those are increased risk of miscarriage. Obviously, we did mention that earlier. So if somebody has endometriosis, their pregnancy will also possibly be more complicated. So their OB/GYN or the obstetrician who's going to deliver them needs to know that they had endometriosis and they got pregnant with or without infertility treatment and that they should be treated as high risk.
So our next question is, can you give a ballpark of the cost related with IVF, and is it ever covered through insurance?
Yes, IVF can be covered by insurance. All major PPO insurances have policies that cover IVF. So it's not the insurance company or the type of insurance, but rather the actual policy that is provided by the insurance company IVF can be covered at 100%. IVF can be covered at 80%. So it all depends on the insurance coverage. When patients come to our clinic, and if they have insurance, we routinely check their infertility benefits. And that includes diagnostic testing, surgical management, insemination treatment, medications, IVF services, freezing of embryos, storage of embryos. So in our office, when somebody comes in, we routinely check on those. And if the patient has coverage, typically we bill insurance. And then patients have copays or deductibles. Once again, all based on their policy. Somebody may have the best PPO type of insurance, they may think, but they may have absolutely no infertility coverage. A person may have another PPO policy from the same insurance company, and they may just have 100% coverage. So it is quite confusing, and that's why every single case we treat, we call insurance companies and get that verification. If somebody doesn't have any coverage at all, then typically self-pay pricing is presented to the patients. And the basic IVF typically starts anywhere from $6,000 to $8,000, depending on the clinic location, what type of IVF it's going to be done. It can go as high as $15,000, $20,000 if somebody's paying medications out of their pocket, and if they're doing genetic testing and freezing of their embryos. So the range, is quite wide because of the needs of each case. And when the patients come in, typically we evaluate their case, and then depending on their case, we provide pricing so that they eventually find out what the issue is, whether they need one treatment or two treatments or a couple of transfers or one transfer. And then based on that, they actually can sign up into different plans. Until somebody comes in for a full evaluation, it's hard to say exactly what the cost will be, but that's the range pretty
So
much.
next question is, do you know if there is any genetic aspect to endometriosis?
There might be, because if somebody has endometriosis in the previous generation, like their mom or their grandmother, then they're at the greater risk for having endometriosis. But oftentimes, when we ask about these family histories, people say no, nobody knows, or they didn't have it. So majority of the time, we don't get that history, the family history. But certainly, there is a correlation, with genetics. It's just that we just really don't know why people have endometriosis. There appears to be some association genetically. It can be hereditary. There are certain dramatic cases and reports and publications where somebody has like three siblings, and like all girls, let's say, and their mom had endometriosis, and like all siblings have endometriosis, or the patient has it, her grandmother had it, and then like her cousins have it. So they're like these obvious family traits that we kind of see oftentimes, but for the most part, when patients have endometriosis, there's actually no family history. So there's some genetic component to it, but it's certainly not the
Okay,
only
so our next
cause.
question is there anything that I can help myself to naturally conceive?
With endometriosis, one must make sure that the tubes are open, uterus is healthy, the partner has good sperm, making sure that that person is ovulating and she has a good, decent egg count, like the egg reserve is good. So once that workup is completed, and if they're younger than 35, they can continue trying on their own. In terms of natural remedies, supplements, there's really not much, nothing proven. I'm sure if you go onto the internet, there'll be like 100 different type of suggestions or certain supplements that may have been proposed to work for endometriosis, but unfortunately, nothing is really proven. I mean, if there was something proven, that we would be doing it already anyway, right? Just keeping a healthy, balanced lifestyle, balanced diet is helpful. Managing stress, exercising regularly, eating healthy, uh, is always recommended for any patient who's trying to conceive. Taking prenatal vitamins or at least folic acid is helpful. Avoiding any inflammatory things like canned foods, anything in a jar, too much fast food, fried foods, excessive alcohol, smoking, drug use. Obviously, that was without saying. Um, can be detrimental to the body. It can increase inflammation and even make endometriosis worse. Stress management is probably one of the most important things. In some women with chronic pelvic pain or endometriosis, acupuncture may be helpful. Some people state that they benefit from herbs. Once again, not proven, but some people say they benefit. So we cannot ignore that benefit, obviously, that they get. So those are some of the things that they can do
Okay.
naturally.
Well, that looks like that was our last question, and that was a great one to end on. So thank you so much for joining us. That was incredibly
Great,
informative,
perfect.
and yeah, we got a lot of good feedback already on the side. So thank you so much. You too.
Thank you so
Bye.
much. Have a good evening. Bye bye.